Okay, welcome to our first YouTube video for Rad Path. My name is Matthew Hartman from Pittsburgh, PA, part of AMSR, the Alliance of Medical Student Educators in Radiology, and we're going to learn some Rad Path today. I want to say these lectures are on the ACR building blocks, which you can access. And we also have an Anki deck of Rad Path flashcards. For instructions, go to the About section of our YouTube channel. So, some disclosures. I'm a body imager with a love for Rad Path. I'll use the kidneys as my template for pathology, but the radiology and pathology principles can be applied to every organ system. We have to remember some embryology. We're going to keep this simple. Remember, we start with two cells. They unite, they multiply a bunch of times. They're going to fold on themselves to form a bunch of tubes. We are made of a bunch of tubes. GI tract is a big tube from mouth to anus. Our GU collecting system is a big tube from renal calyces to urethra. Our vascular system is a big tube with a pump in the middle. Now, pathology. There are only 1 to 6 bad things that can happen to the tube. I call these the Hartman's 6 patterns of pathology. You have an innie, you have an outie, you have narrowing, the tube can be dilated, the tube could be thickened, the tube can be displaced, pushed or pulled. Let's see some examples of these. So here's our tube. You can have an innie, outie, narrowing, dilation, thickening, or displacement. So innie, you have an ingrowth into the tube. Here are the stomach. Now, another Hartman principle of Rad Path, every differential, Mets lymphoma. I ask you, what's your differential? You say Mets lymphoma, you'll probably be right. This is a metastatic melanoma to the stomach. This was a primary gastric tumor. They both look the same radiographically. So the opposite of innie is an outie. Here's a nice Zenker's diverticulum. You could also have a fistula or a perforation causing an outie. Our tube can be narrowed. And it's just like plumbing. If it's narrowed one place, it will be dilated somewhere else. Nice example here is a case of achalasia where we have bird's beak narrowing at the GE junction, and just like plumbing, it's backed up and dilated through the proximal esophagus. This patient's at risk for aspiration. The tube can be thickened. Here we are in the colon. This is thickened. This is normal bowel. Bowel should be 3 millimeters or less. This is like 2 or 3 centimeters, so massively thickened. The mucosa itself is okay, but the submucosa is thickened. What lives there? Well, we have nerves, muscle, and a big part of our lymphatic system. Remember, every Hartman differential, Mets lymphoma. If you guessed lymphoma for this one, you are correct. Displacement. Here we have a big ovarian cystic lesion, which is pushing the colon out of the way. This is a nice example of displacement. Here's another example with a patient with Hirschsprung's disease with a huge stool ball and is pushing, displacing the ureters laterally. So remember, displacement, push or a pull. Now we have our mass. If we can answer these 4 questions, we're doing very well. Is it solid or cystic? Is it infiltrative or expansile? And we'll use the example of the kidney. Is it bean-like or is it ball-like? Our next question, is there fat in there? Fat's our friend, and this will help us with many of our differentials. And then the last question, solitary or moldable? If it's moldable, be thinking Mets lymphoma. So let's talk about cysts. They can occur anywhere in the body. And we will focus on renal cysts. So realize simple cysts are benign, but there are some cystic neoplasms, cystic renal cell carcinoma, and mucinous cyst adenomas of the ovary, just to name a couple. So renal cysts, 10% of renal cell carcinomas can present as a fluid-filled lesion. But we can diagnose a simple cyst on ultrasound, CT, or MRI. Sometimes cysts can be complicated by hemorrhage, infection, or ischemia. And so, ultimately, we always rely on microscopic evaluation. That's the gold standard. But with some radiology tricks, we can make a confident diagnosis. So what's a cyst going to look like? Well, a cyst is a bag of water. On ultrasound, will be anechoic. No solid component. On CT, hopefully everyone knows Hounsfield units, but if you don't, Hounsfield units range from -1,000 to +1,000. Water is 0. So that's pretty close, 2 Hounsfield units. MRI, it's helpful to know T1 or T2. T2 hyperintense, the CSF is bright, and so is our cyst. So we have confidently diagnosed the cyst here. Now we have solid masses. It can be balls or it can be bean-shaped, where the kidney maintains its reniform shape. So solid renal mass, this was our intro case. That was a RCC. And we are going to talk about this ball versus bean type growth for a couple of examples, because we can apply this to the kidney. Here we have a nice RCC. This is a solid ball coming off. Whereas here we have more of an infiltrative mass. Again, that differential, Metz lymphoma. Don't forget that. But again, lymphoma likes to do this infiltrative growth. Here's an MRI, ball type mass. This is a leiomyoma. The actual diagnosis doesn't really matter here. Infiltrative metastasis here. We can use this for other organ systems. Here's the lung. It looks like a ball in there, whereas this is an infiltrative pattern. Here we had the adenoma. This was lymphangitic tumor of spread of breast cancer, again, metastasis. Here's an esophagram showing a focal lesion. There's another esophagram, more infiltrative growth. Leiomyoma here, and again, lymphoma. Remember, Metz lymphoma, every differential, especially if it's multiple or infiltrative. Apply it to the bone. Here we have a focal lesion. This ended up being a chondroma. Here, infiltrative type of process, lymphoma again. The brain, here is a CT with a ball-like lesion coming off. Here's more infiltrative mass in a brain MRI crossing the corpus callosum. This was a MET, could have been a meningioma also, but ended up being the metastases. Here we have a infiltrative GBM. Our next question, is there fat? Fat's our friend. Again, we have to understand Hounsfield units. Fat will measure between -40 and -100 Hounsfield units. Here we have a fatty lesion coming off the kidney. We just diagnosed a renal angiomyolipoma. Here is a female with pelvic pain, and we have a mass with different densities. Here, this component is very dense, 1,000 Hounsfield units. Here, this darker component is -100 Hounsfield units. So fat plus calcium/teeth. This was a dermoid. And we'll see some of these in further Rad Path lectures. So fatty abdominal mass, if we can make that distinction, we have our differential is lipoma, liposarc, angiomyolipoma of the kidney. We just saw that. It's on the adrenal myelolipoma, the teratoma. Now, the last question, is it single or multiple? If you have one lesion, keep looking. If things are multiple, think Metz or lymphoma. Again, every Hartman differential, Metz or lymphoma. So here is a KUB abdominal radiograph, stones, bones, mass, and gas. That's my mnemonic for reading abdominal radiograph. Everything looks good except for the bones. Too many white spots. And this patient had an elevated PSA, multiple white spots. There's our annotations. Every differential, Metz lymphoma. So elevated PSA, this was prostate met. Again, if you have bony Metz, try to divide it into sclerotic or lytic. That will help your differential, and realize breast can be either. So in summary, we learned the Hartman 6 patterns of pathology: innie, outie, narrowing, dilation, thickening, and displacement. 4 questions for every mass. Is it solid or cystic? Is it exophytic or infiltrative? Again, the ball versus bean question. Is there fat in there? Fat's our friend. Single or multiple? Metz lymphoma, almost every differential, especially if there are multiple masses. Thank you very much.